My dear students, in this video, I'm going to answer or try to find an answer to this question, which often puts a dilemma in critical care that whether therapeutic hypothermia provides neuroprotection or it's only a neuroillusion. Let us look into this case. A 50-year-old male collapses in the ward with witnessed VF. ROSC is achieved after 10 minutes of CPR. On arrival in the ICU, the patient has a GCS of E1-VTM3 with no purposeful motor response. Pupils are 2 millimeter reactive. ABG shows a pH of 7.18, bicarb of 16.5, lactate of 9. The MAP is 65 mmHg on NORAD, along with a saturation of 98% with an FiO2 of 0.6. Question is, what is the role of targeted hypothermia or therapeutic hypothermia in this patient? Now, if we want to analyze, we will have to find out why the physiological rationale as to why it should work. Going by history, the earliest recorded application of therapeutic hypothermia in medicine spans around 5,000 years ago. Although its use became widespread since 2002, following the demonstration of both safety and efficacy of regimes which require mild degree of cooling or mild hypothermia between 32 to 35 degrees centigrade immediately after cardiac arrest. So why is it considered useful? It is considered useful because at such a degree, it reduces the cerebral metabolism and oxygen demand by reducing CMR by roughly 6 to 10% per degree centigrade, decreasing the ATP consumption and oxygen requirement in the vulnerable neurons after global ischemia, which helps the brain tolerate the post-arrest low flow and reperfusion better. It limits the excitotoxicity and the calcium-mediated injury by reducing the release of excitatory neurotransmitters such as the glutamate and the dopamine, and attenuating the NMDA receptor activation and the intracellular calcium overload. It also attenuates inflammation, oxidative stress, and apoptosis by blunting the post-cardiac arrest neuroinflammation and reduces the free radical production, thereby mitigating reperfusion-related oxidative damage. But these are not the only reasons. There are some other reasons too, like it preserves the blood-brain barrier and reduces cerebral edema by maintaining the blood-brain barrier integrity, improving the microcirculatory flow, etc. And it also improves the neurological outcome and survival in selected patients, particularly clinical trials and meta-analysis in resuscitated patients with out-of-hospital cardiac arrest, especially it was VF or V2, that is shockable rhythm. They have found higher rates of favorable neurological outcome. And in early trials, it improved survival with therapeutic hypothermia versus uncontrolled normothermia. And this has been confirmed even in Cochrane database. So if you try to figure out where it is clearly neuroprotective, as per the evidences, one, the adult post-cardiac arrest, especially with shockable rhythm, where early RCTs versus no cooling showed a nearly doubling of a favorable neurological outcome. And as I mentioned already, the Cochrane database, which reviewed in 2023 12 studies, nearly 4,000 patients, found an increased favorable neurological outcome versus standard care, including 36 degrees centigrade targeting. That is, the relative risk or the risk ratio was 1.41. And observational cardiac origin VFVT cohorts reported also better short-term neurological recovery and survival with mild hypothermia compared with normothermia. Other than this, where the benefit was clearly neuroprotective was in neonatal hypoxic ischemic encephalopathy, where in term neonates with moderate to severe HIE, cooling to 33 to 34 degrees centigrade for 72 hours, initiated within 6 hours of birth, robustly improved the survival. But there are also areas where the benefit is equivocal or even negative. So these are the traumatic brain injury, where data suggested that therapeutic hypothermia induced ICP improved outcome is can be there, but large multicenter RCTs fail to confirm any routine benefit. So isolated cases or isolated studies have found some benefit, but these have not matured into well-drawn conclusion. Trials in acute ischemic stroke, again, they have faced challenge with regard to the timing, rewarming, shivering, and complications. So no large trials has yet demonstrated clear-cut benefit at a large scale. In SAH and other acute brain injuries, the data are heterogeneous. Hypothermia may reduce ICP but has not convincingly improved long-term functional outcomes in unselected population. Therefore, in order to get the maximum benefit, the approach has changed, shifted from therapeutic hypothermia to targeted temperature management. And if you see that it is an active, precise control of body temperature at a chosen target, which may be hypothermia, that is 32 to 34, mild reduction, 35 to 36, strict normothermia, which is around 36 to 37, or active fever prevention. So if we have such a strategy which encompasses, which is not purely restrictive to 32 to 34 or 32 to 35, but rather it is encompassing a wide variety of conditions, then such targeted temperature can mitigate some of the drawbacks or some of the deficiencies which may be there for therapeutic hypothermia. So this conceptually, the targeted temperature management was introduced because therapeutic hypothermia did not encompass strategies aimed at maintaining normothermia or avoiding fever, although these strategies were also neuroprotective, they were also important. If we look into the difference between therapeutic hypothermia and targeted temperature management, other than the temperature concept, of course, which specifically hypothermic target is there in therapeutic hypothermia, this is extended to up to 36 or 37 in targeted temperature management. But the main goal in therapeutic hypothermia is neuroprotection via induced hypothermia, which shifts to neuroprotection and prevention of temperature extremes, especially fever, because many a times we get fevers, uncontrolled fevers occurring after hemorrhage, intracranial hemorrhage, and the patient keeps getting loads of paracetamol without any effect. And even those patients, neuroprotection can be achieved if those patients can be made normothermic. So this is also one reason. And besides the historical terminology, the fever prevention, in which the targeted temperature management has a definite role, which is not there in therapeutic hypothermia, which focuses more on cooling. The phases that are emphasized are similar in the two, that is induction, hypothermic maintenance, and slow rewarming. So this can be applied to targeted temperature management in patients with hypothermia or normothermia as well. So these are some of the differences that it is important, which makes it clear that therapeutic hypothermia is only a subset of targeted temperature management, which is otherwise much broader. So how can the limitations of classical therapeutic hypothermia be overcome by using targeted temperature management? Because if we use a range of temperature targets, not one size fits all, so we have to overcome that one size fits all strategy. The classical therapeutic hypothermia locked us into that 32 to 34 degrees centigrade, even when hemodynamics, bleeding risk, comorbidities made cooling hazardous. So those they got some extra room by extending it to 36 or 37 degrees centigrade. Targeted temperature management allows 32 to 36 degrees centigrade with strict fever control in fail, shocky, bleeding patients, preserving some neuroprotection while reducing the complications. Then it prioritizes strict fever prevention and stability over uh, deeper ICU. So a major limitation of therapeutic hypothermia has been difficulty in consistently heating and maintaining the target temperature. There were frequent episodes of overcooling, undercooling, and rebound fevers, which actually negated the benefits. The TTM protocols emphasize tight temperature controlled active fever avoidance, which gave similar outcomes to 33 degrees centigrade in broad out of hospital cardiac arrest while lowering the adverse events. It standardized the three phases of induction, maintenance, and rewarming. This TTM addresses by using devices with feedback control to reduce overshoot or undershoot and variability, mandating slow, controlled rewarming to minimize rebound hyperkalemia, hemodynamic instability, and loss of neuroprotection, and embedding sedation, shivering control, and nursing interventions in protocolized care bundles to keep temperature stable. We know that shivering is also a very important factor. And if there is shivering, the cerebral metabolic rate increases, the oxygen consumption increases, and the mismatch between supply demand of oxygen is also bound to increase. So this is also mitigated in targeted temperature management. Then TTM individualize exclusion, inclusion, and depth based on risk. One limitation of blanket therapeutic hypothermia is exposing low benefit or high risk patients to complications of hypothermia like arrhythmias, infections, coagulopathy, electrolyte shifts, etc. So this can be avoided or prevented by modern TTM stricter selection, adjusting depth or reduction, considering normothermia focused TTM, etc. Integrating TTM into a multimodal neuroprotection bundle, because another limitation of therapeutic hypothermia in trials is that it was sometimes treated as a standalone magic bullet rather than one element within a comprehensive post ROSC care. Targeted temperature management framework explicitly integrates temperature control with optimized hemodynamics, oxygenation, ventilation, and glucose control. Seizure detection and treatment, timely angio when indicated, and careful prognostication at appropriate times have also been made into this strategy. TTM causes improve implementation, monitoring, and staff training, because the TTM programs have tried to fix this by developing hospital-wide TTM pathways and checklists, training nurses and physicians in shivering management, temperature variability reduction, and complication surveillance. These are all important as a bundle approach to prevent the adverse effects of hypothermia, and continuous auditing of adherence and outcomes to refine targets and indications. So move from a fixed protocol to truly personalized TTM, which is the key thought in the days of precision medicine, has been highlighted. And recent analysis and the TTM2 era data highlights that hypothermia at 33 degrees centigrade may not outperform active normothermia for all corners, and that indiscriminate cooling can waste resources and cause harm. So the emerging answer within this TTM is a personalized strategy with individual risk stratification, choice of 33 versus 36 degrees centigrade, variable duration, focus of avoiding both fever and unnecessary side effects rather than reflexively cooling every post-arrest patient. So this is the device that we have in our institute, which we use in all patients in whom there is either hypothermia or where we have to increase the temperature, or patients are having fever to control fever. So this is used, and it is very comfortable machine. We connect the Arctic gel pads and the patient temperature, then use the control panel to select the patient profile. As you can see here in this panel, the patient controlling the patient to 36 degrees centigrade. As we can see that the patient's temperature is reading at 37.8 degrees centigrade. The system uses a probe feedback and internal algorithm to adjust the water temperature automatically, which is reflected continuously on the control panel. And throughout TTM, we watch the main screen for current versus target temperature, trend direction, alarms, therapy mode, etc. So my final take-home message would be that targeted temperature management is about strict active control of temperature, which is usually 32 to 36 degrees centigrade, with vigilant fever prevention and not just cooling to 33 degrees centigrades. It offers modest but real neuroprotection after cardiac arrest when delivered early, consistently, and part of a full post-ROC care bundle. The depth and variation should be individualized, choosing the safest target that one can implement reliably rather than reflexively using deep hypothermia for everyone. Thank you very much.